Hello everybody, this is Dr. Ashur. Today we are gonna continue our series of videos about management of peptic ulcer. In the previous video we talked about the pathophysiology of the peptic ulcer as well as the regulation of gastric acid production. Today we are going to continue this journey by dealing with the treatment of peptic ulcer, where we will talk about two major classes of drugs that are used for treatment of peptic ulcer, namely the H2 receptor antagonists and proton pump inhibitors. We will cover the mechanism of action, pharmacological actions, uses, kinetics, adverse effects, and drug interactions. So before I go into details in these two classes of drugs, I need to review with you like a link between the physiology and the pharmacology that comes on the top of the physiological knowledge. So this is a very, very wonderful figure from pharmacology, Goodman and Gilman, pharmacology book. This is like collectively contains the physiological mechanisms of acid production and protection by mucus and bicarbonate, okay, and the drugs that are used for treatment of peptic ulcer. So we said before, acid secretion could be induced by neuronal, right? Remember, endocrine or paracrine fashion, right? So when it comes to neuronal, we said sight, smell, anticipation of food, taste of food, okay, will activate the parasympathetic nervous system, which will release acetylcholine, which will act on this ganglion cell in the enteric nervous system. This will release acetylcholine, which work on muscarinic receptors on the enterochromaffin-like cell, which produce histamine. Histamine, okay, will act on H2 receptors on the parietal cell. Okay, H2 receptors, as we said last time, they are what? They are GSPCR, GS protein coupled receptors that can activate adenylate cyclase, which can increase cyclic AMP, which activate protein kinase A, which activate the translocation of the pump from the cytoplasm into the membrane of the parietal cells, and fusion of the pump in the membrane, and then the release of H in exchange for potassium. That's why it is proton potassium pump, or HK ATPase, or just simply proton pump. This H production or release will be coupled with the chloride channel, which also will release chloride. So now I have Cl, H, so HCl, I have the hydrochloric acid in the lumen only. They don't, these guys, these mates, they don't meet until they are in the lumen. Otherwise, it's going to be disaster here, right? So this is one. We said also the endocrine part, which is the release of gastrin from the G cells and the antrum. Gastrin, we said, has two mechanisms. One of them, the major one, is to activate the release of histamine from the ECL cells. Histamine again will do the same job as we said before. Okay, so this is the endocrine, and the paracrine, of course, is the histamine itself, because it's nearby. It acts in a paracrine fashion on the parietal cell. Okay, all of these will culminate into the release of H, which meets with the Cl, so now we have HCl production. Okay, so this is collectively the mechanism of the production. Okay, so for the we have also the protection part. Remember, we said we have two arms. Okay, we have the aggressive factors and we have the protective factors. The protective factors, on the top of them are the mucus and the bicarbonate that are produced by the superficial epithelial cells. These are the cells that are facing the acid, so they have to be very well prepared to meet this very corrosive, very aggressive acid, as well as the digestive enzyme pepsin, okay, which is in the lumen, as we explained last time, is very active, okay. So this is produced by these cells in response to many factors, including prostaglandins, which are produced from the arachidonic acid by the action of COX, and this including like prostaglandin, this will release prostaglandin E2 and prostaglandin I2, the prostacyclin, and this will activate EP3 receptors, which will inhibit acid secretion, and as we said last time, they will activate EP3 receptors on the superficial epithelial cells to release mucus and bicarbonate, and also they increase the blood flow, so these cells will be happy having nutrients and oxygen. Okay, so I think that's it for the part of the physiology. When it comes to the pharmacology, we'll start with whatever we started with, the H2 blockers. Okay, so H2 blockers will work here. Okay, H2 antagonists. Okay, and then proton pump inhibitors will work here, inhibit this pump. Okay, the proton potassium pump. Then the antacids will just neutralize the acid in the lumen. We have also the muscarinic antagonist will inhibit the, specifically they will inhibit the M1 receptor. This is the one that's used for the treatment of peptic ulcer. Start from the beginning, this pyrinzipine, antilinzipine. We'll talk about them in the next lecture, inshallah. In addition, also we have the bismuth and other drugs that can eradicate the H. pylori. We have drugs that can help with the release of mucus and bicarbonate. Okay, we have these non-steroidal anti-inflammatory drugs that can aggravate the situation by inhibiting the production of prostaglandins, which are protective to the gastric mucosa. And as you see here at the end of this here, the pH of the stomach is here, pH is 7 around the epithelial cells. However, in the lumen, it's about 2 in the gastric lumen. Okay, so these are the classes of drugs used for treatment of peptic ulcer: H2 receptor blockers, proton pump inhibitors, anti-H. pylori drugs, prostaglandin analogs, anticholinergic agents, antacids, and ulcer protective agents. We'll talk today about these two classes, the H2 blockers and proton pump inhibitors. We'll start with the H2 receptor antagonists, also called H2 blockers. They have been developed in early 1970, and they were one of the most commonly used drugs worldwide until the advent of the proton pump inhibitors, and also the knowledge about H. pylori. That's one of the main positive factors of peptic ulcer. Then the proton pump use, went up, and the H2 blocker use declined. So anyway, the mechanism, they are histamine H2 receptors. They block the binding of histamine to the H2 receptors, so they inhibit the basal secretion of HCl. Okay, basal without meal, without anything, or meal stimulated acid secretion by binding to H2 receptors on the basolateral membrane of the parietal cells, as you have seen in the previous slide. Then the gastric secretion is decreased, and also the concentration of pepsin will decrease. You'll see here in this graph we show last time that pepsin needs HCl to be activated from the pepsinogen into pepsin. So no wonder if pepsin is decreased, right? They are highly selective. Yes, they don't affect H1, H3, or H4 receptors. They only activate or inhibit, the H2 receptors. They decrease gastrin and acetylcholine-induced gastric acid secretion, as we just mentioned in the previous slide about the mechanism of actions of the drugs. We said gastrin activates release of histamine from ECL. Acetylcholine also activates release of histamine. So both, in some part, depends on its histamine. So if you block histamine, you block this gastric acid secretion induced by gastrin and acetylcholine. They suppress 24-hour gastric acid secretion by about 70%. They are very efficient. They mainly inhibit nocturnal basal acid secretion, which mainly depends on the histamine. This accounts for their efficacy in suppressing nocturnal acid secretion. Because nocturnal acid acidity is very important determinant of duodenal ulcer. Okay, so very important in determining the fate and the prognosis of the duodenal ulcer, knowledge about the nocturnal acidity. So the H2 blockers are adequate therapy in most cases of duodenal or duodenal ulcer. They have modest effect on meal-stimulated acid secretion because this depends on gastrin and acetylcholine. We said this, remember gastrin last time we said the main mechanism works through the ECL. But there is a lesser role, they can also activate parietal cell directly without need for histamine. Acetylcholine can activate the muscarinic receptors directly without need to go to activate ECL to release histamine. So these are histamine independent mechanisms, so they are modest when it comes to meal stimulated acid secretion. So these are the four most common H2 blockers: cimetidine, ranitidine, famotidine, nizatidine. They are similar when it comes to the mechanism of action, but they are different in terms of potency, kinetics, and drug interactions. This is the structure of histamine. You are not required to remember the structure, but just look at these are kind of histamine antagonists. They are histamine antagonists. They are similar to histamine, okay, here, so they can trick the H2 receptors and bind to them, but they are not histamine. Okay, as you see here, there are big similarity between this structure and these structures in cimetidine, ranitidine, famotidine, and nizatidine. Okay, the comparison of these drugs, we have cimetidine. Relative potency, we'll consider it as 1. It is the prototype drug. It's the first drug that has been described as H2 blocker, so we'll give it just 1. Okay, then if there is a drug that's more potent, we'll give it more fold. Less, we will give it like half or 1/4, whatever. So cimetidine, the dose is to achieve 50% in acid inhibition for 2 hours is 400 to 800, okay, and it's used 800 milligram at bedtime or 400 milligram twice. Then ranitidine is more potent, nizatidine more potent, famotidine is much more potent. As you go more potent, you decrease the dose, of course. Okay, when it comes to the kinetics, they are absorbed rapidly from the small intestine with a peak plasma concentration within 1 to 3 hours, which is very good. Cimetidine, ranitidine, famotidine, all except nizatidine have very significant, very fast hepatic metabolism. So their bioavailability decreased by about 50%. Absorption, please pay attention. Some drugs, the food will delay absorption, okay, but the absorption may be enhanced by food, and both proton pump inhibitors and H2 blockers their effect are decreased by concomitant use of antacid. You have to space them out by about 2 hours. The serum half-lives of these 4 drugs range from 1 to 4 hours. However, the duration of action depends on the dose given. They are cleared by combination of metabolism and renal excretion. Dose reduction is needed in patients with renal or hepatic insufficiency, and also in elderly patients, because these patients mostly they have less efficient hepatic metabolism. Uses, they are used to promote healing of gastric and duodenal ulcer as easy, okay, to treat gastroesophageal reflux disease, okay, the reflux of the acid from the stomach to the esophagus, to prevent the occurrence of stress ulcers. These ulcers are ulcers in the patients with a very severe disease, like patients with trauma, sepsis, major surgery, okay, they can develop ulcers, so they can also use for this, and also to prevent bleeding from stress-related gastritis. Adverse effects, they are tolerated generally by most patients. Adverse effects occurs in 5% of patients. They are generally mild, maybe headache, diarrhea, drowsiness, fatigue, muscular pain, diarrhea, and constipation. Less common side effects include CNS, confusion, delirium, hallucination, and slurred speech. Cimetidine is kind of unique in some side effects, and there are also drug interactions. When it's used in high dose, it decreases dihydrotestosterone binding to androgen receptors. So when it comes to male, we can expect gynecomastia, reduced sperm count, and impotence. Okay, it also inhibit the cytochrome P450, that hydroxylate, and inhibit the metabolism of estradiol, the female sex hormone, so they can lead to galactorrhea in women. They also can cause some blood dyscrasias, including thrombocytopenia. Drug interactions, cimetidine. We said cimetidine is unique in these in adverse effects and in inhibition of cytochrome P450. So it will inhibit metabolism of many drugs that undergo hepatic metabolism. So they can accumulate to toxic levels, including sulfonylureas, these oral antidiabetic drugs, nifedipine, phenytoin, the antihypertensive drug, antiepileptic drugs, theophylline used for bronchial asthma, phenobarbital, imipramine, metronidazole, warfarin, and many others. Ranitidine and nizatidine, famotidine binds less avidly to the cytochrome P450, so have much less interaction as compared to cimetidine. Okay, antacids, of course, reduce absorption of all H2 blockers. Okay, when used concomitantly, you have to make a gap of about 2 hours. Ketoconazole absorption depends on the acid medium. They love acid medium, so if it decreases acidity by H2 blocker by proton pump inhibitors, this will decrease the absorption of ketoconazole. The second class of drugs used for treatment of peptic ulcer is the proton pump inhibitors. Mechanism of action of these drugs, they inhibit gastric proton potassium ATPase, also known as the proton pump, and are the most potent suppressors of gastric acid secretion. All over all the classes we talked about, this is the most potent one. They are prodrugs. They require activation in the acidic environment, which is a good thing. So you need acidic environment. So after absorption, the prodrugs like omeprazole, lansoprazole, whatever, diffuse into the parietal cells in the stomach and accumulates in the acidic secretory canalicula, where it is activated by proton catalyzed formation of whatever this sulfonamide. So proton catalyzed, so they need the H from the acidic medium to be catalyzed into the active form, which is the thiophilic cyclic sulfonamide. This is the active form. Thiophilic means that it loves sulfur group, okay? Cyclic, we'll see the structure in a moment, and it's sulfonamide. This is the structure itself. This activated form with the sulfonamide form binds covalently with the SH groups of the enzyme, the sodium potassium pump. So, the sulfur-containing amino acids include cysteine, right? Cysteine contains SH group. So it can bind to the cysteine in this protein, the proton potassium ATPase, okay, and irreversibly inactivate this enzyme. Okay, acid secretion, because there is an irreversible binding between the sulfonamide active form of the proton pump inhibitor and the enzyme, so the body has no solution except to sensitize a new proton pump. Proton pump is a protein, so DNA, RNA protein, but this will take some time, okay? Need to be sensitized and then insert in the luminal membrane, and then the potassium proton exchange will occur. This provides prolonged up to 24 to 48 hours suppression of acid secretion, despite the much shorter half-life, which was about 1 to 2 hours of the parent compounds. In typical doses, PPIs can diminish production of acid, either basal or stimulated. Remember, there in the H2 blocker, the effect on the stimulated acid secretion, the mean stimulated acid secretion was modest. Here it inhibits everything, okay? They can, that's why they inhibit this by about 80 to 95%. Very efficient. They block the final step in acid production. Whatever you are coming from neuronal acetylcholine, paracrine, histamine, endocrine, gastrin, whatever you are coming, then you need the proton pump, and then they will inhibit it at the end, just waiting for you on the gate. Okay, so they will inhibit the last step. So whatever the stimulating factor, they will inhibit the acid secretion. So these are the, I just combined the structure with the examples of the drugs. The prototype drug is the omeprazole, the first one that has been discovered, then lansoprazole and the other pantoprazole, okay. So just I'd like here to highlight the fact that omeprazole is converted into the, all of them could be, but just we'll take omeprazole as an example, okay. So it will be converted into the cyclic, thiophilic cyclic sulfonamide, this guy, which loves the enzyme. How this happens? This is the omeprazole. Please focus here, okay? This part, and then go, this is the H environment, the acidic environment, okay? This goes with the previous slide, previous slide. This will go for the sulfonic acid. Look here, this is the what happened. There is a bond here that started between these two nitrogen groups, nitrogen atoms, I'm sorry. And with the release of some water, this sulfur will bind to this nitrogen, so this will form this cyclic. Look here, okay, there is no cycle here. There is no cyclic here. This is a completely cyclic sulfonamide, okay? This pump it's a protein, contains one of the amino acids, cysteine. It will bind this SH group of cysteine irreversibly, okay? Because this sulfur is very hungry to deal with another sulfur, okay, and bind this enzyme, the proton pump, irreversibly. That's why the duration effect is very long. Pharmacokinetics, they are very rapidly absorbed, they are highly protein bound, extensively metabolized by hepatic, mainly by liver enzymes. Bioavailability here is reduced by food. Remember, the H2 blocker, the bioavailability, or the absorption increase in the presence of food. So you take them after meal. These guys, you take them on an empty stomach. They have short half-life, maybe about 1 to 1.5 hours. But the effect lasts to about 48 hours because of the irreversible inhibition of the pump. They undergo rapid first pass and systemic hepatic metabolism, but negligible renal clearance. So mainly they undergo hepatic metabolism. That's why dose reduction is not needed for patients with renal insufficiency, but is required with patients with severe liver impairment. Uses easy now to promote healing of gastric or duodenal ulcer, to treat GERD, gastroesophageal reflux disease, where the acid, okay, goes up through the cardiac sphincter to the esophagus, okay. Well, it can cause even erosive esophagitis, which can maybe, if it's not treated, could go to or develop, the patient can develop Barrett's esophagitis, which may, God forbid, may culminate into esophageal adenocarcinoma, okay? Used for this when it's unresponsive to H2 blockers. To reduce the risk of duodenal ulcer recurrence associated with H. pylori, it's in one of the main regimens. Okay, it's almost there in almost every regimen for treatment with H. pylori. You find the PPI, okay, to eradicate H. pylori. We will deal with it or talk about it in next video. The administration for treatment of the Zollinger-Ellison syndrome. Zollinger-Ellison syndrome is a tumor in the duodenum or the pancreas that secretes gastrin. So tumor keeps secreting gastrin increases the HCl production. It's called also gastrinoma. Okay, so it could be used for this one. The mainstay for treatment for this one. Treatment of recurrence of non-steroidal anti-inflammatory drugs. The patients using these drugs for a long time, they can develop a peptic ulcer. So to prevent this, you can use these drugs. So they could be used for treatment of along with the non-steroidal anti-inflammatory drugs to prevent the peptic ulcer. Prevention of rebleeding from peptic ulcer, prevention of stress-related mucosal bleeding, as we explained before. Adverse effects and drug interactions. They have mild adverse effects. The most common side effects are nausea, abdominal pain, diarrhea, constipation, flatulence. Sometimes maybe myopathy, arthralgia, headache, skin rash. Okay. The loss of gastric acidity, as we explained before, the H2 blocker, remember ketoconazole, we said it loves the acidic medium. So ketoconazole and iron salts may be affected by the loss of gastric acidity, so their bioavailability will be decreased. Hypergastrinemia, okay, may predispose to a rebound hypersecretion of gastric acid upon discontinuation of the therapy. Remember, we said before, less acid, more gastrin. Less acid, more gastrin. So now they are used for long term, so more gastrin, more gastrin. So when you stop them, gastrin is still there, so it can activate the parietal cells and D cell cells, so they can continue to increase the production of gastric acid upon discontinuation of the PPI therapy. Drug interactions, they are metabolized mainly by hepatic cytochrome P450 enzymes, therefore may interfere with the elimination of the drugs cleared by the same route, such as warfarin, diazepam, and cyclosporin. Clarithromycin, which is a macrolide, can inhibit the cytochrome P450, so it will inhibit omeprazole metabolism and can increase its plasma concentration. Okay, that's it for now. Thank you for your attention. And I will see you soon, pretty soon, in the second part of drugs for management of peptic ulcer. See you. Bye.